Community Health Center, Valayam as assistant surgeon. I have a post-graduation in general surgery. So today I'm entitled to take one session. So I am just briefly discussing about some benign aspects of surgical proctology. So we know surgical proctology is a vast topic coming from small benign papillomas up to malignant neoplasms of the anal canal. So I'll be just overviewing some benign pathologies regarding the surgical proctology, which we come across our routine OPD. I think it will be efficient. So straight away, I'm moving on to the topic for today. So surgical proctology, benign anorectal diseases. So coming to the famous quote from the Bible of surgery, Bailey and Lau, if you don't put your finger in someone's rectum, you might put your foot in it. So it itself indicates the importance of doing a rectal examination in a patient. So there is no justification not to do a rectal examination in a patient who is warranted. And just because we are reluctant to do, but we are not justified in denying a rectal examination in a patient who is really warranted. So my scope of discussion today is, one is hemorrhoids or piles, anorectal abscess, then anal fissures, anal fistula, and pilonidal sinus. So these are some of the common benign proctological conditions coming across in our routine OPDs. So coming to a brief anatomy of the anal canal. So we know anal canal is a continuation of the rectum, which is approximately 4 centimeters in length, extending from the anorectal junction up to the anal verge or the anus. The upper part has an anal column, anal wall, and the epithelial lining, that is a squamous, the mucocutaneous junction of the anal canal, is delineated by a line called a dentate line. So anything below the dentate line is very painful condition. So it has got a highly sensitive area below the dentate line, but above the dentate line, the pain is relatively insensitive in that area. So any condition that is occurring below the dentate line will be very painful. So dentate line is basically the line that is delineating the mucocutaneous part and the inside endodermal part of the anal canal. So the arterial supply of the rectum anal canal includes superior, middle, and inferior rectal arteries, which divides into anterior and posterior branches. So the newer concept of the pathologies regarding the anal canal, you will see. One is called the anal.
Slide movie in the
Hello.
Slide movie in the slide show.
Hello. First slide doctor.
Hello.
Hello. Okay.
Okay. Thank you. So coming to the anatomy of the anal canal, we told it is 4 centimeters in length and extending from the anorectal junction up to the anal verge. The upper part has got anal column, anal walls, and dentate line. And the arterial supply of the anal canal is mainly by the superior, middle, and inferior rectal vessels. So there is a newer concept called the anal cushion concept. That is, the main pathology regarding the anal canal is due to the defective anal cushion. Anal cushion is nothing but an aggregation of blood vessels, venules, arteriovenous connections, smooth muscle stroma, and elastin tissue in the submucous of the anal canal. This is thought to be a mechanism which imparts a competence or a continence of the anal canal for solid, liquid, and gas. So anything causing disruption of this anal cushion will lead on to the anal pathologies like hemorrhoids, fissures, and fistulas. So it is supposed to be a penalty we are paying for the erect posture we evolved in course of our evolution, that the gravitational effects cause the gradual laxity of this anal cushion, and most of the patients will get hemorrhoids in later part of the life, at any part of the life. So this was what we are discussing. So rectum and anal canal is delineated by a dendrite line, and below the dendrite line it is very pain sensitive area, and above that it is a pain insensitive area. So we can see laterally there are, I think the slides are moving, right? Hello?
hello.
Not moving.
ഇപ്പൊ ആനൽ കനാൽ എന്ന് പറഞ്ഞ സ്ലൈഡിലുള്ളത് അതിലുള്ളത്.
Diagram അല്ലേ കാണുന്നത്?
Dr. MUFSIL.
Hello?
Dr. MUFSIL will change to slideshow mode. Slideshow mode.
I'm
No, this is the opening mode, no?
No.
Slideshow. There is a bottom right corner.
Yeah, that's one. That's the same.
But next to after 75%, move to the click there.
Hello? I don't know.
ഡോക്ടറെ നെക്സ്റ്റ് സ്ലൈഡ് ആണ് വേണ്ടത്, ഇത് കഴിഞ്ഞില്ല.
ഞാൻ ഞെക്കുന്നുണ്ട്, എന്താ വർക്ക് ചെയ്യാതെന്ന് അറിഞ്ഞൂടാ. ഹലോ?
ഹലോ, ആ സ്ലൈഡ് ഷോ ഒന്ന് കൊടുക്കുക. 75%. അത് കൊടുത്തിരുന്നോ അവിടെ?
കൊടുത്തിരുന്നു.
MUFSIL?
Hello?
Yes.
ഹലോ?
ഹലോ,
കാണുന്നുണ്ടോ അപ്പൊ?
ആക്ച്വലി ഒന്നും കാണുന്നില്ല, ബ്ലാങ്ക് ആയിട്ടാണ് ഉള്ളത്.
MUFSIL, you go on.
Yes.
യെസ്, ഇപ്പൊ കാണുന്നുണ്ട്.
So this was what we are discussing about the diagrammatic representation. So we can see the rectum, the dendrite line which delineates the pain sensitive and pain insensitive area. So laterally we can see through vertical lines of that tissue, that is the internal and external sphincter. The medial one is the internal sphincter and the lateral one is the external sphincter. So we know the internal sphincter is an involuntary muscle, and then external sphincter is a voluntary muscle, which imparts the continence of the anal canal. And laterally to this area there is a compartment called the ischiorectal fossa. So coming to the common symptomatology of the benign proctological conditions, one is bleeding. So bleeding is the most common symptomatology we are coming across the proctological condition. The bleeding can be either fresh bleed or a melena or a dark colored stool will be there. It can be mixed with the stools, or it can come before the passing of the motion or after passing of the motion, depending upon the condition. Like in hemorrhoids, it can be usually seen mixed up with the fecal matters, but in fissures, there is a fresh capillary bleed. It can occur before the defecation. The next is the pain, which is the most common symptomatology is the pain, which is very troublesome for the patient, and most of the patient will be complaining about pain in anal condition, which is very worrying and irritating for the patient. Then tenesmus means the incomplete evacuation of the feeling of incomplete evacuation of the feces. Then discharge per rectum, either serous, mucoid or purulent discharge can occur. Then altered bowel habits, constipation and loose stools can be mixed with each other. Then pruritus, that is excessive itching of the perianal region, can also be seen. And coming to the examination tools we are using in proctology, the most important one is the basic one is the digital rectal examination or rectal examination, which anyone can do in a OPD setup. And next one is the proctoscope that usually use the operator and the scope. You can just visualize the anal canal up to around 2 to 3 centimeters you can visualize. Then sigmoidoscope and colonoscope. But the initial and the most important one is the digital rectal examination. So digital rectal examination is the most important diagnostic tool for identifying rectal and anal pathology. It can diagnose fissure in ano, fistulas, mass per rectum, prostatic pathologies like hard prostatic nodule or prostatic masses, and even gynecological pathologies can also be identified using per rectal examination. So what are the things we are looking in digital rectal examination? So we can do initially inspection, we can identify any excoriation due to any chronic irritation of the perianal skin can cause excoriation. Any candida infection or moniliasis can be identified. Any external openings of fistula in ano, any external hemorrhoids, any bulges other than the hemorrhoids like papillomas can be identified.
ഡോക്ടറെ സ്ലൈഡ് ഷെയർ കൊടുത്തല്ലേ? ഇപ്പോഴും സ്റ്റക്ക് ആയിട്ടാണ് കാണുന്നത്.
കൊടുത്തതാണല്ലോ.
ആ ഓക്കെ, കുഴപ്പമില്ല, കണ്ടിന്യൂ ചെയ്തു, പ്രശ്നമില്ല. ഇപ്പൊ മൂവ് ചെയ്യാൻ തുടങ്ങിയിട്ടുണ്ട്. യെസ്, കറക്റ്റ്.
Then coming to palpation. In palpation we can, that is per digital examination, we can identify the anal stenosis or stricture. Sphincter tone, which is most important one, that is sphincter tone is very important in identifying sphincter spasm, which is the main pathology behind the anal fissures causing pain. So in a tight sphincter or the anal spasm is very much high, the patient will have more severe pain and patient may need surgical intervention. Then mass lesions can be identified rectally and even we can take biopsy from that. Then ballooning of the rectum can occur in intestinal obstruction, and prostate can be palpated for masses. Uterine mass, even uterine mass can be felt through rectal examination. Melena, we can inspect the finger for melena and bleeding, and induration along the fistulous tract also can be identified by digital rectal examination. Coming to our first pathology, that is the hemorrhoids or piles. Hemorrhoids is nothing but a swollen, inflamed dilatation of the lower rectal veins. It can be either external, internal, or internal external, depending upon the relation to the dentate line. That is, if it is above the dentate line, we call it as an internal hemorrhoid, and below the dentate line, we call it as an external hemorrhoid. So the common sites of the primary hemorrhoids, it is in relation to the location of the veins. That is the left lateral, that is a 3 o'clock position, right posterolateral, that is a 7 o'clock position, and right anterolateral, that is a 7 o'clock position. These are the primary positions of the hemorrhoids that a patient can have. That is 3 o'clock, 7 o'clock, and the 11 o'clock. Also, hemorrhoids can occur in between these areas. That is known as secondary hemorrhoids. Any other position other than this, we call it as a secondary hemorrhoids. So, what are the etiologies behind the hemorrhoids? One is portal hypertension can present as hemorrhoids. Then chronic infection of the anal lining, that is perianal cryptoglandular infection of the anal lining can cause laxity of the anal cushion leading on to hemorrhoids. And diet, that is constipating diet, less fiber diet, etc., can lead on to formation of hemorrhoids. Then consistency of the stools, hard, dry fecal matter can also induce this laxity of the anal cushion leading on to hemorrhoids. Then anal hypertonia, extensive spasm of the anal canal, may be idiopathic or due to any other reasons like fissure or anything. Then aging, obesity, and even pregnancy can induce hemorrhoids. Coming on to classification of hemorrhoids, that is first degree hemorrhoids, second degree, third degree, and fourth degree. First degree means painless bleeding with stools. Only there is painless bleeding with stools, and only on proctoscopy examination we can identify the hemorrhoids. Second degree, there is prolapse during defecation, but it returns by itself. And third degree, the prolapse is there, but it persists, and only manual reduction can reduce the hemorrhoids. That is third degree. And fourth degree, it is permanently prolapsed. So these are the 4 degrees of hemorrhoids. So we can say image of a hemorrhoids. We can see primary and secondary hemorrhoids in this. So apart from 3, 7, and 11 o'clock, there are hemorrhoids in between also. It is also there is associated mucosal prolapse also in this case. So coming to complications of hemorrhoids, that is a bleeding. Usually it is the mixed with stools. The bleeding will be mixed with stools. Then strangulation can occur. That is very large hemorrhoids can occur. Strangulation and gangrene of that can occur. Portal sepsis. The sepsis can enter into the portal circulation and lead on to portal sepsis and portal pyemia. Then fibrosis and stricture of the anal canal can also occur. So this is a thrombosed hemorrhoids. You can see it's a painful condition. The hemorrhoidal mass getting thrombosed, and it will be it is usually seen outside in prolapse condition, and there is edema and severe pain, and it requires conservative management initially by analgesics and antibiotics, etc. And patient may need surgical intervention soon in these patients. Coming to treatment options for hemorrhoids. For external hemorrhoids, thrombose 1 more than 72 hours, diet modification, pain control, and sitz bath is advised. And less than 72, the emergency we can consider surgical, because as the time progresses, there is much edema, and the sutures may not be adequately tightened while doing surgery. So after 72 hours, it is ideally we can ideally do a conservative management by pain control medications, antibiotics, and sitz bath, and also laxative can be used. And if it is less than 72 hours, we can consider emergency surgical excision. And non-thrombosed one, diet modification or surgery. And if large and very poor hygiene, we can again consider for surgery. So these are some of the management options for internal hemorrhoids. Grade 1, usually diet modification and lifestyle modification is enough. If it is not controllable, we can opt for a banding of the hemorrhoid. Just a simple OPD procedure. We can just pull up and band the hemorrhoid. And for grade 2 hemorrhoids, again diet modification and banding can be attempted, and still it is persisting, we can go on for a hemorrhoidectomy. And grade 3 hemorrhoids, we can do a stapler hemorrhoidectomy, that is PPH excision or hemorrhoidectomy, and banding can be done in patients who are not fit for surgery. And grade 4 definitely requires surgery, either stapler or open hemorrhoidectomy. And even laser surgeries are there now, evolving up for hemorrhoids. So diet modification includes high fiber diet, stool softness like lactose, etc. can be given. And basic idea is to avoid the constipation. And first and second degree not responding to conservative treatment, sclerotherapy is another option, using sclerosing agents like sodium tetradracyle and phenol, almond oil, etc. can be used for sclerosing the bile mass. So surgery, open technique, that is a Milligan and Morgan method, usually we are performing. Then closed is Ferguson's, not being used much now. And post-op complications include urinary retention, bleeding, and stricture. So that is regarding the hemorrhoid part. Coming to this is the stapler hemorrhoidectomy, or it is known as procedure for prolapse and hemorrhoids. It's actually a prolapse hemorrhoids are more treated with this rather than others. It's just lifting up the anal mucosa and giving a circular or donut-like excision. Actually, it is the surgery ideally for a prolapsed hemorrhoids. Coming to our next pathology, that is the anal fissures. So anal fissure is a linear tear in the lower midline of the anal canal distal to the dentate line. And as we know, if it is distal to the dentate line, it is a very painful condition. Most commonly, it is usually seen in posterior aspect 90% of the cases, followed by anterior and lateral. Are easily seen by visual inspection on anal verge than palpation. So it is easily seen. So fissures can be acute or chronic. It's a very painful condition, and chronic fissures or non-healing fissures can present as a protrusion of the skin outside the site of the fissure, anal fissure, presenting as sentinel pile or sentinel tag, and inside the anal canal it can be a hypertrophy of the anal papilla. Hypertrophied anal papilla can be seen. So in the diagram we can see the left side we can see a anal fissure, and outside we can see a sentinel pile, and inside a protruded thing that is known as the hypertrophied anal papilla. And second diagram we can see a fresh anal fissure. So etiology of the anal fissures, again constipation is the most important culprit in anal fissures. Low fiber diet, previous anal surgeries, trauma, infection, diarrhea, anal sex, and these are some of the etiology behind the anal fissures. And the male-female preponderance ratio is almost equal in fissure in ano. Coming to presentation. So fissure usually patient vein with excruciating pain, which is the most common symptom of fissure in ano. It's very worrying symptom. Then episodes of constipation. Actually, patient will be very much afraid of going to the washroom because of the exclusive pain, and patient will present as episodic constipation. And fresh bloods in stool are usually seen in fissure in ano. And chronic fissure, we can see sentinel pile and anal papillae, and itching is another common feature associated with chronic fissures. So treatment of the fissure in ano include usually conservative management can be given by using topical application cream, smooth muscle relaxants like diltiazem, nifedipine gel, lignocaine gel, etc. can be given, and stool softeners can be given, or laxatives like lactose, etc. can be given. Then sitz bath, that is warm water. A patient should be advised to sit in a warm water for 10 minutes after passing the motion. It will give a good pain relief for the patient. Then analgesis can be given, diet modification, that high fiber diet, and ask the patient to drink plenty of water, and treat the constipation, causes of constipation underlying like hypothyroidism or any other condition can be treated for treating the constipation, and topical ointments. Anal dilatation can be done. And the definitive procedure for anal fissures is the lateral sphincterotomy, which relaxes the internal sphincter. Some fibers of the internal sphincters are divided, and it will give a laxity of the anal sphincter and release the anal spasm, and it will give immense relief of pain for the patient and helps in the healing of the anal fissure very fastly. And very large and non-healing fissures, we can also do an anal advancement flaps. So this is the sphincterotomy procedure. We can see the left, the internal sphincter is being hooked and some fibers are divided. So we can feel the definite laxity of the anal canal, anal sphincter after the doing this surgery, and which will give the adequate relief for the patient. So coming on to the next pathology, that is the anorectal abscess. So anorectal abscess is a very painful condition. Patient will present with throbbing pain, pyrexia, mostly due to the anorectal abscess are mostly due to cryptoglandular infection of the perianal region. It can be also due to underlying systemic illnesses like Crohn's disease, tuberculosis, hidradenitis, and even malignancy. The common sites of the anorectal abscess are perianal region, ischiorectal region, and intrasphincteric region. And the treatment include incision and drainage of the abscess. So in the diagram we can see the anorectal abscess. There is a reddish swollen area and bulging is present, which needs incision and drainage. So these are some of the common sites of perianal abscess. So you can see the perianal region and the intersphincteric abscess, and laterally we can see the ischiorectal abscess, and even it can occur in the supralevator area. So next is the fistula in ano, which is another common pathology in the proctology. So chronic abnormal communication usually lined to some extent by granulation tissues, which opens externally to skin or the buttocks. This is a fistula in ano. So externally it is communicating to outside and internally to the inside to the anal canal. So coming to the classification of the fistula in ano, usually we use a Parks classification. So it is intrasphincteric, that is in between the external and internal sphincter. Transsphincteric, that is piercing both the internal and external sphincter. Intersphincteric accounts for about 45%, transsphincteric about 30%, and lesser ones are the suprasphincteric, that is above the sphincter muscle, and extrasphincteric, that everything completely above the sphincter muscle, that is accounts for only 5%. It is a very complicated fistula. So low type fistulas are usually opening below the anorectal ring, and which is very easy to manage. And high fistulas usually is troublesome and may require multiple or stage procedure. And we know the Goodsall's rule. Goodsall's rules means the anterior fistulas are opening in a relatively straighter path compared to the posterior fistulas, which are opening in a curved or horseshoe path. Coming to the etiology of fistula, primary, it is due to obstruction of the anal canal, anal gland suppuration leading on to the fistula. So it can be a idiopathic infection occurring to some unknown reason, cryptoglandular infection chronically leading on to fistula, but it is very rare. Usually fistulas are seen with secondary, either iatrogenic. Patient may have underwent incision and drainage for any abscess which have lead on to fistula formation. Then inflammatory, like systemic conditions like tuberculosis, Crohn's disease, and other HIV, etc., can cause fistulas. Then infection and malignancy. These are some of the other secondary causes of fistula in ano. So presentation, patient will have skin maceration. So owing on to chronic irritation of the skin over there due to discharge, skin maceration will be there. First discharge can be seen. It can be either serous discharge or feculent discharge can also occur. Itching is another common symptom associated with fistula in ano, and it can also present with the localized infection on and off, leading on to pain and swelling over the perianal region, and unpleasant odor, which is more worrying symptom by the patient. The feculent discharge can produce a unpleasant odor to the patient. So diagnostic modality of fistula in ano, it can be diagnosed clinically by rectal examination if it is a lower tract, but internal opening, which is if it is very high, it is difficult to identify clinically. So we need another investigation, and the gold standard investigation is the MRI fistulogram. X-ray fistulogram is not routinely used now, and USG can identify some low-lying, small, uncomplicated fistulas can be identified by ultrasound, but the gold standard investigation is the MRI fistulogram. Coming on to the differential diagnosis of fistula in ano, one is the pilonidal sinus and another is the perianal abscess. So coming on to management of the fistula in ano, so very low fistulas, uncomplicated fistulas, we can just lay it open. Just simple fistulotomy or opening of the fistula tract is enough. If it is much more complicated, little more higher, we can go in for a fistulectomy, that is removal of the entire fistulous tract, which is very essential in treating the fistula because there is high chance for recurrence whatever method we do. Then Seton surgeries That is, non-absorbable sutures are being passed through the fistula tract, and we just tie it off. This helps in adequate drainage of the fistula tract and avoid the cutting of the fistula sphincter muscle, which lead on to incontinence. So we can avoid that by doing a seat-on surgery, but it is a it requires multiple sittings, and it's a patient complaints are much less in seat-on surgeries. The newer surgeries are there, like fibrin glue. The cyanoacrylate glues are there, which you can just apply into the fistula tract, and it can induce the closure of the fistula tract. Then very large fistulas require advancement, anal advancement flaps. And another newer modalities are the WAFT or video assisted fistula therapy and ligation of interfistular tract. These are some. And the most commonly the evolving procedure is the laser surgeries or laser fistula closure, which is being very popularized now. It is done as daycare procedures, and the patient complaints are very good and relatively painless, and the wounds are much less in laser surgery compared to other conventional surgeries. So patient complaints are being good for the laser surgeries nowadays. So this is a low fistula. We can see the fistula probe being introduced, and it's a very low fistula, and we can mostly this fistula can be treated by a fistulectomy or fistulotomy. Coming to the last pathology, that is the pilonidal sinus. We are discussing about the pilonidal sinus of the natal cleft. So as a term, we know the pilonidal means it's a nidus of the sinus leading on to nidus of hair. Actually, near the natal cleft, owing on to the chronic irritation, there are some pits, hair pits occurring in the midline area, which lead on to a dimple formation, and the hair particle, the broken hair follicles will fall inside the crypt and forms a sinus. So it forms a nidus inside, and pus will be collected inside, forming onto pilonidal abscess, and recurrent infection can occur, and it will ultimately form a pilonidal sinus. So pathophysiology means there is an invader hair. It's only it's ideally usually seen in patients who are very obese, hairy, and prolonged sitting patients. Can cause the hair to invade inside through the hair pits and causing to the hair penetration. And due to negative pressure effects from inside, the hair follicles will be sucked inside, leading on to nidus formation and leading on to pilonidal sinus. And the main pathology is culprit is the vulnerability of the skin, prolonged sitting, then obese patient, abnormal curvature of the sacrum, etc. are some of the causing factors of this pilonidal sinus. Risk factors include obesity, local trauma or irritation, sedentary lifestyle, prolonged sitting, deep natal cleft, and family history. These are some of the risk factors associated with the pilonidal sinus. Clinical features. There is a if it is pilonidal abscess, patient will present as acute onset of pain and swelling, and if it is burst, patient will present as intermittent mucopurulent discharge, recurrent persisting pain, fever, etc. So patient is presenting as a pilonidal abscess, patient may need emergency incision and drainage, and definitive procedure include excision of the pilonidal tract. So this is a pilonidal sinus. We can see multiple pits. So these are the hair pits usually seen in the midline. So the entire tract should be excised to get adequate relief. Otherwise, recurrence is very common following the pilonidal surgery. So this is what we are telling about. You can see the nidus of hair inside. So there is a dependent area through the hair pit, and going on to recurrent infection, the nidus will get infected and forms a tract leading on to sinus formation. So diagnosis, usually it is diagnosed clinically without any imaging itself, we can identify that this is. And if it is very complicated and low-lying pilonidal sinus, we may need MRI or USG to rule out any fistula, perianal fistula. And differential diagnosis, perianal abscess, folliculitis, and hidradenitis. So treatment, again, the problem with the pilonidal sinus like fistula and ano is the recurrence. Rate of recurrence is very high. The primary closure going on to 50, nearly 50% of recurrence after primary closure after excision. So usually we do other procedure rather than usually we are doing excision and leading on to secondary healing by secondary indentation. We lay it open usually and allow it for secondary healing. But newer procedures are there like flap surgeries, Karidakis operation, or Z-plasty. The basic idea of treating the pilonidal sinus is the breaking the midline. We are avoiding the dependent area, the midline area, and we are just lateralizing the midline. That is what we are hoping to do with the surgery of pilonidal sinus. So that we can either do a Z-plasty or a Karidakis surgery or a Limburg's flap or a quadrangular flap can be done, and other advancement flap also can be done. And other procedures include, again, laser surgeries are being popularized in pilonidal sinus also. So these are some of the, this is the Z-plasty. You can see the midline, the initial midline, the straight line is broken into a zigzag manner. Is a excision and the Karidakis procedure, that is midline we are excising and lateralizing the midline. You can see the finally a curved line is formed. In spite of the straight midline, we are getting a curved line. This is the Limburg's flap, another surgery. The quadrangular excision is done and the rotation flap is done from lateral area, and this is known as a Limburg's flap. So these are some of the flap surgeries we are doing for pilonidal sinus, and the newer modality is definitely the laser surgeries. So that is regarding the benign anal pathology. So taking on message, do not hesitate to do a per-rectal examination even in busy OPD. So whenever indicated, we should not hesitate to do a per-rectal examination. So per-rectal examination doesn't need any special skill, and any doctor can do the per-rectal examination. We can diagnose many diseases by doing just a spending or 2 or 3 minutes for doing a per-rectal examination. So don't hesitate to do a per-rectal examination. Then, so that is all. Some other pathologies are there. So hopefully we'll discuss in later lectures. So thank you all.
Thank you, Dr. MUFSIL, for your nice presentation. If you have any doubts, so you can ask. Any doubts regarding the topic? Everybody is free to ask. MUFSIL doctor, slide share on stop you. Hello. Doubts ആർക്കെങ്കിലും ഉണ്ടെങ്കിൽ ചോദിക്കാം കേട്ടോ.
ഡോക്ടറെ സ്ഫിങ്ക്ടറെക്ടമി കഴിഞ്ഞാൽ ഇൻകോണ്ടിനൻസ് ഉണ്ടാവുമോ?
നമ്മൾ യൂഷ്വലി നമ്മൾ ആഡിക്കേറ്റ് സ്ഫിങ്ക്ടറോട്ടമി ചെയ്യുള്ളൂ. ലോവർ ഫൈബേഴ്സ് ഒരു 2 സെന്റിമീറ്റർ മാക്സിമം നമ്മൾ കട്ട് ചെയ്യുന്നുള്ളൂ. സ്ഫിങ്ക്ടർ നമ്മൾ ഡയഗ്രം കണ്ടില്ലേ, സ്ഫിങ്ക്ടർ ഒരു വെർട്ടിക്കലി മുകളിലേക്ക് ഒരു എക്സ്റ്റെൻഡ് ചെയ്യുന്നു. നമ്മൾ ഒരു ഐഡിയലി 1 to 2 സെന്റിമീറ്റർ മാത്രമേ നമ്മൾ കട്ട് ചെയ്യുന്നുള്ളൂ.
പക്ഷെ സ്ഫിങ്ക്ടറെക്ടമി കഴിഞ്ഞാൽ ചില പേഷ്യൻസ് പറയാറുണ്ട് അവർക്ക് ഹോൾഡ് ചെയ്യാൻ പറ്റാറില്ല.
ഇനീഷ്യലി ചില പേഷ്യൻസിന് കുറച്ചൊരു പ്രശ്നം ഉണ്ടാവും. ആഡിക്കേറ്റ്ലി നമ്മൾ ചെയ്യുകയാണെങ്കിൽ ഇമ്പോർട്ടൻസ് ഒന്നും വരില്ല.
അത് വൺസ് അങ്ങനെ കട്ട് ചെയ്ത് പോയി കഴിഞ്ഞാൽ പിന്നെ എന്തെങ്കിലും ചെയ്യാൻ പറ്റുമോ? അതിന്റെ ഇത് റീഗെയിൻ ചെയ്യാൻ എന്തെങ്കിലും ചെയ്യാൻ പറ്റുമോ?
സ്ഫിങ്ക്ട്രോപ്ലാസ്റ്റി സർജറി ഉണ്ട്, സ്ഫിങ്ക്ട്രോപ്ലാസ്റ്റി ഉണ്ട്, ഫ്യൂച്ചർ ചെയ്യാം.
ഓ അങ്ങനല്ലേ. ഓക്കെ.
ഇനി ഡൗട്ട്സ് ആർക്കെങ്കിലും ഉണ്ടെങ്കിൽ ചോദിക്കാം. ഡൗട്ട്സ് കൂടുതൽ ഇല്ലെങ്കിൽ നമുക്ക് സെഷൻ വൈൻഡ് അപ്പ് ചെയ്യാം. എനിവേ മുഫ്സിൽ ഡോക്ടർ, ബിഗ് താങ്ക്സ്. ഒരു എക്സലന്റ് പ്രസന്റേഷൻ ആയിരുന്നു. ഒരു കുറച്ച് പേര് നമുക്ക് ഇന്ന് പാർട്ടിസിപ്പൻസ് ആയിട്ട് ഉണ്ടായിരുന്നു. അപ്പോൾ ഈ CME പാർട്ടിസിപ്പേറ്റ് എല്ലാവർക്കും ഒരു ബിഗ് താങ്ക്സ് പറയുന്നു. അപ്പം we'll see you soon on the next Friday with another topic. Thank you. Thank you, Dr. Mufsil.